Hello, friends. So I'll give a overview on this interesting topic, role of steroids in toxic epidermolysis necrosis or Steven Johnson evidence. So what is the evidence? So this is in context to a patient right now we have in our ICU with toxic epidermolysis necrosis, and it's a very rare condition, friends. So you would possibly get in 1 to 2 per 1 lakh sort of a incidence rate. So it's very rare, and it's terribly important intensivists are aware of what is the evidence for steroids, because when you read very cursorily, it says controversial, but if you dig into evidence, there are at least around 100 articles. So it's a huge body of evidence there. And most of this evidence you have to synthesize from the meta-analysis of these studies. So I have posted a link. So there's already a nice video that I have done on fever with skin rash in ICU. So I request you all to watch that video as well. It is a continuum of that. And we have seen few tens in our ICU. So I'll just take you through one case discussion. So this is the case report we had published in Critical Care and Shock in 2014 about toxic epidermolysis. So I'll just take you through this case. So PBLD is problem-based learning discussion. So there was a 36-year-old female who came with high-grade fever with temperature for 5 days with conjunctival suffusion, who had received antibiotics for 2 days and then developed skin rash since 1 day. Obviously, she came with shock. She was intubated and ventilated. Infective workup was negative. So the skin lesions, she had erythema, which then progressed to urticarial plaques. Then she had a bulle. So this was the progression of the skin symptoms, and then there was an epidermal sloughing. So this is a typical progression of Steven Johnson's or toxic epidermolysis necrosis. And this was the clinical sort of a characterization of this patient who was in our ICU, who had urticarial plaques like this. And if you see, there was a relative truncal sparing. This is the case we had published. And if you see the healing, it is even more scary when there is re-epithelialization and there is sloughing. So this is how it happens, epidermal sloughing. So it is almost like a severe burns that you would see, where there is whole lot of epidermal sloughing that you would see. And it is quite gory when you see these cases. And this we successfully managed. We published this case report, and this patient got nicely discharged, and her skin completely recovered without any scarring. So this is the case we published in 2014. And as I'm speaking, friends, so we have another interesting case who is again come with toxic epidermolysis necrosis with more than 30% of involvement. So if you look into scientific literature, so when you say Steven Johnson syndrome, the characterization of the skin involvement would be less than 10%. If it is 10 to 30%, we call it as Steven Johnson syndrome and 10 overlap. So that's what we call it. If it is more than 30%, which currently our patient is having, then we call it as toxic epidermolysis necrosis. So it's a nice little image you can keep in mind. So the more severe forms, we call it as toxic epidermolysis necrosis. The less severe, you call it as Steven Johnson syndrome. So as I said, this is the case we had published in 2014. So let's look into just the prevalence of 10 and Steven Johnson's. It's very rare, friends. It's around 1 to 2 per 10 lakhs is what has been referenced. Maybe nowadays you are seeing little more commoner because of the cancer therapies that are increasing. It is a medical emergency and the condition can be fatal. So please understand, and these cases tend to come to ICU, and every intensivist should have some clarity with the medical management. So the common drugs that are cited, which are commonly purported as the inciting trigger, are antibiotics. So our patient had received cefpodoxime, which is a cephalosporin oral tablet for fever and a skin rash a doctor had prescribed. Along with it, our patient had taken NSAIDs. And other drugs that are more commonly purported are antiepileptics and chemotherapy drugs for cancer. And allopurinol also has been cited because our patient had taken antibiotics, NSAIDs, and allopurinol for joint pains. So this was the context of our patient. So when you look at the pathophysiology, I think we don't need to dwell into the whole pathway. So what typically happens is the keratinocyte is what gets affected. They undergo apoptosis. So they manifest HLA receptors on their cell surface, So the cytotoxic T cells get activated and they release a lot of cytokines, as you can see. And this leads to apoptosis and self-destructive sort of a perpetuation of keratinocytes is what happens. So your whole keratinocytes get affected, they get apoptosis. So your whole dermal surface, epidermal sloughing and dermal surface gets affected and you will have a skin peeling. So this is a typical sort of a pathophysiological underpinnings of this condition. And as I've already said, the skin rashes, it starts with erythema, urticarial rash, plaques, and then they go into epidermal sloughing. And in severe cases, they can have neutropenia and thrombocytopenia. And multi-organ dysfunction can happen secondary to the whole cytokine storm itself that happens. And due to secondary infections that these people get vulnerable because of the whole skin surface that gets exposed. And you have to literally typically look at it as a burn sort of a situation. And treatment is principles of Burns therapy. And we'll look into steroids because the whole topic that I'm interested is to see whether steroids have any role in mitigating. Because if you look into literature, when I gave the first talk, maybe in 2000, 2 to 3 years back or 4 years back, so we would say steroids are plus or minus controversial. But now looks like there is a good body of evidence which is favoring the use of steroids. So that's what I'm interested in to look in. And all intensivists need to have clarity whether we use steroids, what is the dose of steroids, whether steroids in combination we need to give, and what are the newer development. So when you look into body evidence, there's a heaps of literature. So early steroids, overall, if you distill out the core essence, early steroids is shown to be beneficial, but also at the same time, it is controversial. If you look at the guidelines, so there is a guideline that's come from Indian Dermatological Society, which was published in 2018. The suggestion is to give prednisolone on a higher dose, 1 to 2 milligrams per kg per day. The key essence is to start steroids very early on, less than 72 hours, and then to be tapered and stopped over 7 to 10 days is what the guidelines suggest. Or one could use DEXA around 8 to 16 mg per day. And methylprednisolone pulse therapy has been advocated. See, all the literature, if you look, there are no randomized control trials. They all come from a big case series or retrospective sort of a studies and cohort studies. So when you use methylprednisolone pulse therapy for our patient, we gave methylprednisolone. The suggested dose is 500 mg to 1 gram over 3 days. And what is the evidence for this? So if you look, most of the evidence for Stevens-Johnson syndrome and toxic epidermolysis necrosis, fortunately, comes from Asian countries, mainly from Taiwan and Japan. So if you see, this was a sort of a meta-analysis that came from Japanese authors, where the pulse therapy, methylprednisolone, showed reduction in mortality, with mortality being as less as 0 to 7%. And it does reduce the inflammatory cytokine storms that tends to happen in these sort of a patients. So there is a reasonable body of evidence with meta-analysis suggesting that pulse therapy lessens the mortality and it lessens the cytokine storm. So now the question is, do we just confine ourselves to only steroids or do we give combination therapy? So there are studies which have shared steroids with IV immunoglobulin. They tend to be synergistic and they show reduction in mortality. And they all come again from these Japanese and Taiwanese studies. And they've shown the time to recovery also is shortened when you use steroids with IV immunoglobulins. The immunoglobulins, typically the studies, the case series or retrospective studies that I've used is 0.4 to 0.75 grams per kg per day into 5 days, or much higher IV immunoglobulins, 1 gram per kg per day to 3 days. So in our patient currently who's in ICU, we have used methylprednisolone pulse therapy based on whatever robust sort of a meta-analysis that we have had, along with IV immunoglobulin at 1 gram per kg per day. Today is the second day we are giving, and we would intend to stop at the end of third day. And if you look the body of evidence for the combination, there is a network meta-analysis that come from Taiwan, 67 studies, and they've taken 2,079 patients, and they have shown that steroids along with IV immunoglobulins lessens the mortality and lessens the time, shortens the time for recovery. So we have a reasonable, we don't have a randomized control because it's a rare disease. You cannot have randomized control trial. So the best is what we have is the meta-analysis of all the case series and retrospective studies at this point of time we have. So this is a decent enough sort of a literature that we have at this point of time to convince ourselves that combination is the way to go. And now the recent development that is happening is on etanercept. So when you look at Cochrane review, which is the mother of meta-analysis, Cochrane review 2022 published by UK group, they have looked at etanercept given twice a week has shown mortality benefits. So etanercept typically acts by inhibiting tumor necrosis factor alpha receptors. And it has shown it shortens the time for re-epithelialization, because the whole problem is your whole epidermal sloughing has happened. There needs to be formation of new skin and re-epithelialization has to happen. So this Cochrane review has shown that etanercept shortens the time for re-epithelialization. So again, a schematic representation of how etanercept. So these are all the tumor necrosis factor. This is the receptor. So etanercept goes and blocks this tumor necrosis factor receptors and inhibits the action of these on these cells and prevents the cytokine storm. And again, this Cochrane review database published in UK is from a meta-analysis of 9 studies with 308 patients. So there is a reasonable body of evidence evolving suggesting the benefit of etanercept. But now we need to have an answer whether steroids are here to stay, whether steroids we combine with IVIG or steroids we combine with etanercept. So there are other older case series have looked into steroids with cyclosporine, but the newer studies are focused because right now I'm only interested in looking into the studies from 2020, from the last 5 years. Last 5 years, predominantly they are linked into steroids with IVIG or steroids with etanercept. So now we need to have an answer as to whether we combine steroids with IVIG or etanercept. And the etanercept dose is 25 to 50 mg, and 50 mg is to be considered for someone who weighs more than 65 kgs. And very simple drug, and etanercept is available in India. It costs around 6,000 rupees. So this may be a better drug to consider than IVIG is what my initial thought was. And what is the evidence for that? Because it is a cheaper and maybe easier to administer. So this was the study we have, which has compared 3 arms, steroids with etanercept versus steroids with IVIG versus only steroids. So this was a retrospective study that came from Taiwan, which showed that the reduction in mortality was much more better when steroids with etanercept was used as compared to steroids were with IVIG. And this was a retrospective sort of a study of 242 patients. So this is the evidence we have where etanercept seems to have performed better as compared to steroids with IVIG in this particular retrospective study that came from Taiwan. So this is all the evidence we have. So if you dig into the evidence, you'll get around a 50-page document with around 100 studies. So when you distill out, I think this is the essence we have. So the take-home message is if you have a toxic epidermolysis necrosis, you have to give steroids. Higher dose steroids is sort of the signals are towards higher dose. So you can use either 2 mg per kg and taper out 7 to 10 days, and you can even consider methylprednisolone if our intent is to halt the perpetuation of the skin lesions. And now the signals that are strongly coming is steroids have to be combined with either IVIG or etanercept. I think if you have to subscribe to the most recent evidence that is evolving, etanercept seems to be having a reasonably good sort of an outcome benefit with steroids. Of course, IVIG can be used, but the cost can be sometimes prohibitive, is something that can be kept in mind. So that's about it, folks. So I request you all to submit your valuable work to our Journal of Acute Care. Of course, you can visit my website to rehear to this lecture. Thank you. Thank you, Mananda.